Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friend. Welcome to this week's episode of the Healing Pain Podcast. On today's episode, we discuss how language and logic impact the management of pain and the experience of pain with physical therapist Asaf Weisman. Each week on the Healing Pain Podcast, we discuss the latest pain science, as well as perspectives on pain so that you can understand pain better. The field of pain science is the study of pain, nociception, and the lived experience. The International Association for the Study of Pain defines pain as an unpleasant sensory as well as an emotional experience associated with actual or potential tissue damage. Nociception is different. It's the neural processing of encoding noxious stimuli throughout the nervous system. Pain and nociception are a different phenomena, and pain is always a personal lived experience that's influenced by many, many factors. Asaf Weisman is at the forefront of studying many of the aforementioned topics. He is a physical therapist, a PhD candidate, and a lab manager of the Spinal Research Laboratory at Tel Aviv University. He has 20 years of clinical experience as a full-time musculoskeletal physical therapist and studies musculoskeletal medicine, spinal health, as well as chronic pain. On today's episode, we discuss how language impacts pain, the idea of being able to process or reprocess nociception and/or pain, how modern pain therapies are at times helpful, at times may not be so helpful, and at times may even be harmful for people living with pain. We discuss the positive and the negative aspects of cognitive approaches to chronic pain, and we discuss some of the more popular pain neuroscience analogies or metaphors and how they may not be so acceptable to people living with pain. This is definitely one of the longer episodes I've recorded. There's a lot packed into this information, and we move kind of fast. If you enter into this episode, I'd like you to keep three things in mind. The first one is to keep an open mind and notice where your own personal beliefs or biases may be challenged at some point during this interview. The second is know that the language we use and our communication is a vital part of pain care and caring for people with chronic pain. And the third is realize that cognitive and psychological processes have an important place in pain care. However, they are just one component that contributes to pain, along with biological, social, epigenetic, as well as contextual factors. And with that in mind, cognitive interventions that use analogies and metaphors should be specific to the lived experience of the person you're working with who has pain. There's no one-size-fits-all cognitive behavioral approach for people with pain. Okay, without further ado, let's begin and let's talk about the language and logic of chronic pain with physical therapist Asaf Weisman. Hey there, Asaf. Welcome to the Healing Pain Podcast. Great to have you here.
Yeah, thanks for having me. Great for me too.
I'm excited to talk with you about all things pain. I know that you are working on your PhD. That's exciting. Congratulations on that. I know a lot of it centers around pain, and you've already put out.
Well, not really. Well, my PhD is not kind of pain related. It's it's related to the spine, computer vision in radiology of the spine, but it's somehow somewhat related. So it's not totally off topic, but yeah, but we do a lot of pain work in our laboratory. So
and you of course have published papers about pain, kind of more from a theoretical, philosophical perspective, which I appreciate because it makes us all think about how we approach pain, how we think about pain, how we treat pain, and of course how we do research in that area and kind of the nomenclature that we use, which I know you have discussed a lot. Where does this kind of deep interest you have about thinking about pain in a different way come from?
Yeah, I think it started with my skateboarding. I've been skating since I was like 13, 14. And I hurt myself a lot. It's a very dangerous sport. And my interest in pain started from there. And then I started getting tattoos. And I have a very good friend who is a tattoo artist. And, tattoos are also kind of like mingled with pain. And started reading about pain even before I started my physio school. So I've been reading pain literature for, I think, now 25 years. Been reading a lot of literature, and I must confess that most of the stuff I read is only professional and pain related. That's what I mostly read. Like, I don't read any novels or fiction or stuff like that. I just don't. And I learned how to incorporate it into my work. So I guess I'm doing good.
Yeah, it's funny how once you get involved in science, sometimes it pulls you away from fiction reading. I do the same. I don't really read much fiction at all. Most of what I read is like yourself, is science related. So we're going to talk about a lot of concepts today, right? And I think the two most important concepts or definitions that we probably want to clarify first is, according to your view, what is pain and what is nociception? Or how do you define nociception, or how do you define pain, and what's the difference? Because I think that'll inform a lot of what we're going to talk about here today, right?
Yeah. I came up with a really, I think it's a good analogy. Lately, I came up with it, and I think it's a good one. Like, for me, if I want to paint a picture, okay, I'm going to need brushes. I'm going to need maybe pens, maybe, I don't know, like panda colors, or it doesn't matter. I need a lot of substrates to paint the picture. Now, the picture, the end product is going to be pain. But the substrate is also the canvas. We're going to need a canvas, right, or paper, and we're going to need all those colors. And these are all, well, nociceptors and the apparatus of nociception. But they are different. Like, I think it's clear by this example that the picture itself is not the materials and is not the substrate, right? I hope, do you agree? Like, what do you think about this analogy? Because I think it really, I also put it on Twitter and people kind of liked it. So pain is an experience. It's also defined by the International Association for the Study of Pain as an experience. And what is an experience? Like, we all use this word, and it's kind of like, I think it's quite clear to most people when they say the word, when they use the word, like, I experienced that. Oh, what a great experience that was. And pain is that, it's an experience. And nociception is the biological substrate that creates our experience of pain. And basically, all our experiences, everything that we know, who is this we that I'm talking about? Like you, Joe, I am Asaf, but like, who are those we? Like, those are our conscious selves, like this movie that runs before our eyes. Like, it's more than a 3D movie. It's like, it's a multi-dimensional movie, because we've got smells, we've got like sounds, we've got like inner interoception, like we've got inner feelings. It's like this multi-dimensional film that runs before our eyes, and psychologists call it the mind, or like this movie is called The Mind by them. So like, our conscious selves are experiencing that, and all of that is the result of biological substrates that are creating those experiences. That's like, I think it's kind of like, it's a no-brainer. Like, we all, like, we live the world through our senses and through our biological apparatuses and substrates that we have like, they're there for us to use them and experience the world. So we have to differentiate between pain, which is the conscious experience, like this this thing that we become aware that there is something wrong with our bodies.
So let's piece through that just a little bit. So I like the idea that, I mean, obviously pain is an experience. And you said, I think at one point you said it's like life is an experience, right?
Exactly. Like, we go, like, from birth to death, it's all one big experience.
Right.
Even death and even birth are experiences. Some of us probably like nobody really remembers his birth moment, and nobody is there to talk about their death. But even when people go through death, they experience something.
Right. So if you go watch the World Cup live, you're going to have one type of experience. And if you go to a Broadway show, that's a different type of experience. And then pain in and of itself is a completely different type of experience. So as human beings, we move in and out of these experiences, or these experiences are in some way generated based on what's happening inside our body, as well as what's happening in the environment around us.
Exactly.
Mm-hmm.
Yeah. And like pain is a word that we use to communicate that we are experiencing something wrong within our body. So pain is a word, and it's a word that we use when we our conscious selves become aware of sensations that we don't like.
Mm-hmm. And you mentioned the International Association for the Study of Pain's definition, which has sensation or sensory built into it. Mm-hmm. Do you like their definition overall?
I do. I think it's I think it's a very good definition. Definitely. Yeah, sure. There are problems. It doesn't encapsulate everything that there is to encapsulate about pain, which is immense, but it's a very good operational definition. It's like it's good for clinicians, it's good for patients, it's good to for scientists to work with, and it's quite a good definition. Of course, it's not perfect, but then again, I don't think that we can ever have like the optimal definition for pain. Mm-hmm. But it's a very good one. It's quite ingenious, and it's quite amazing that they were like in 1979 they were able to conceive it. Mm-hmm. I think it's a very important definition. It has been changed a bit, like 3 years ago, something like that, but not that much, because it's a good definition.
Yeah, a lot of people waited on that, right?
Yeah, the change was underwhelming, but then again, like I know, like from one of my colleagues, Professor Cohen, he's in the taxonomy committee, and he said, yeah, like they were just they found it really hard to to change it. It's pretty good.
Yeah, it's good.
Pretty good for what it is. So it was not an easy task to change it. But they did change a lot the notes that accompany
yeah. There's about 6 or 7 of those that are notes that are
side notes. Yeah, like they changed quite a lot of them.
Yeah. And if you read through those notes, I mean, you really have to understand kind of the full breadth of pain to really understand what those notes kind of really mean, and then how do you take action on that, right? What one term do you have the most problem with, would you say, in the world of pain?
I think it's a sensitivity to pain.
Sensitivity to pain.
Sensitivity to pain, yeah. Or insensitivity to pain.
Or like someone hasn't that when someone has chronic low back pain, they have increased pain sensitivity.
Yeah, this term is a misnomer. It's like it doesn't make any sense when you consider the existing ontology that we have for pain. It doesn't make any sense. It's like illogical. Insensitivity to pain doesn't make any sense. You can't be sensitive to an experience by definition. Like if we say pain is an experience by definition, then you cannot be sensitive to it. It's like saying like, oh, I'm sensitive to the color red, to my experience of the color red. It doesn't make any sense. Now, pain is a response. It's not a stimulus, right? And people tend to ascribe stimuli the qualities of pain, but stimuli are just stimuli. Like pain does not exist out there in the world where it can come and poke you. Like, I can poke you with a pin, and if I just do it lightly, it's not going to be anything noxious. It's not going to do anything. But if I poke you just hard enough, it's going to turn noxious, and then you're likely to have the experience of pain, and that's a reaction. It's not something that you can be sensitive to, okay? And it doesn't make any sense, but somehow people are still using it like to describe protocols that they're doing to assess their pain sensitivity, but it's actually not. What they're doing is just checking sensitivity to stimuli, to different stimuli. Now, and that can change quite a lot between people, like, and between the different hours of the day and between the different temperatures in rooms, you can get totally different results. And it's got nothing to do with pain, the reaction. Okay, the thresholds of those stimuli might change, and like many things can affect those thresholds. That kind of bothers me.
And you hear it, I mean, you read it all the time in research. They usually say something along the lines of 25 patients were exposed to a painful stimulus.
Yeah, exactly. Now, a stimulus in and by itself is not painful. Stimuli can be either noxious or innocuous.
Right.
They cannot be painful. Like, the quality of the stimuli is not pain. Its quality is either noxious or innocuous. Like, the same pinprick can be innocuous or noxious. It's like a spectrum. But pain is the organism response to that stimuli, and they're often conflated, and it needs to be separated. And like, for many years, I've had a problem with like, I tended to think, and I still think, that people like with what is called congenital insensitivity to pain, which again is a misnomer, because we just said you cannot be insensitive to an experience that you never had.
Right.
Like, those people never, like, supposedly never had the experience of pain, so how can they be sensitive to it? And also, like, I'll add, like, try to think like being allergic to your own allergy, right?
Mm-hmm.
Like, your allergy is a reaction. Can you be allergic to your own reaction? You cannot. So it doesn't make any sense. But I for many years, I still think that we can learn a lot from those people who are labeled as congenital analgesic or congenital insensitivity to pain. They hold the key for many insights that we can get from them, like about nociception, not about pain. Now, we wrote a paper about that, about those people, and for years I used to be confused, and because like the literature conflates a lot, like the pain and nociception, and it's actually a really old term. It's like from the 1930s, congenital insensitivity to pain. It was first labeled congenital analgesia. And then, like, I think in the 1940s and 50s, they started naming this in the literature like congenital insensitivity to pain. And when I went back into I read all the old literature. Like, we did like a really thorough literature review of all the old case studies from the 1930s, 40s, 50s, 60s. And we started reading, and we started seeing a lot of strange things in them, a lot of discrepancies. For example, the first case by Dearborn, it's like from 1934. He described this guy was a circus. It was a circus act, and used to be called the human pincushion. Like, he would get crucified. Like in front of people, like really crucified, like they would nail his hands with a hammer. And when you read Dearborn, you already see the discrepancy. Like, when you read it, like, Dearborn writes, like, this man had never had pain besides headaches. and that's really strange. Like, wait, isn't a headache pain?
Sure is, yeah.
Sure is. And it's written right there in Dearborn, 1934. Yeah, like, he never had any pain besides a few headaches, and that's it. So how can you say that this guy never experienced pain? He obviously did. But something in the language, like, our language affects the way we perceive things. And when you start reading all the case studies of congenital insensitivity to pain, you start seeing a lot of discrepancies. They say he never felt pain besides a few stomach aches here and there, and besides like a knee pain here and there, and eventually, like, you realize that it's kind of a myth. Like, these people do feel pain, but our language, the language we use, like, where we turn pain into a noun, like into a thing that that exists or doesn't exist, then it's only the result of language when you use it as a noun. If you read those case studies, it's quite apparent that those people do feel pain. But I'm working on a continuation for that paper, where we say what is noticeable from those case studies is that those people have like a blanket insensitivity to external noxious stimuli, but they do not have they have intact deep nociceptors, and until today, we haven't identified like a complete absence of nociception, because I don't think these people would even be able to live one day, because our the deep nociceptors are so crucial for everyday functioning. Like when we have to go to the toilet, because if we're going for number 1 or number 2, we have nociceptors that are signaling that we need to go. Right? And I think that we won't be able to observe like a complete absence of nociception, because these people just don't stay alive. Like they die at infancy, and because they can't urinate, they can't do anything.
So really what you're saying is, to date, we probably have not found a human being that never experiences pain, but we have identified people that have changes in the way they process nociception. And I want to make that distinction for people. There's a difference when we say processing nociception versus a term that is commonly used now, which I have a problem with, which is processing pain. So there's a couple of things that lead to that. So one is the idea that we have pain fibers. One is the idea that we have pain pathways. And the other is the idea that we have a pain system, right? So those things like kind of come together. And when we have a pain fibers and pathways and systems, then there are some, I think, well-studied people saying that we can, quote unquote, reprocess pain.
I strongly disagree with this approach and this way of looking at things. Again, pain.
So do I, by the way. I think it's the wrong direction that we should be. I think we should go in the opposite direction, actually.
Yeah, we cannot process pain because pain is the outcome of all the processing.
Right. Okay, so it's like this idea, like if we get, so you take a grain, so to speak, right? And you process a grain, which means like you take the grain, you take the shell off it, you grind it down, and you process it so that it becomes, let's say, bread, right? But ultimately it's still some form of a grain. Like what your paper says, and I want to point people to the paper, like the paper that Asaf wrote is called "Pain is Not a Thing: How That Error Affects Language and Logic in Pain Medicine." I'll link to it in the show notes. You can read it, and the idea of pain processing is in there. And the challenge of pain processing is in there, because it's the idea that you can physically take someone's pain as if it's a thing and reprocess it, so to speak. And my question is always, first of all, people don't want pain. So why would they want to take their pain and reprocess it, so to speak? The logic the logic is poor.
It doesn't make any sense, because again, what I said, pain is a reaction. Okay, it's an end result. Like all the processing that preceded that pain is like
pain is the outcome, essentially.
It's the outcome. It's like it's there. It's done. It's like that's what it is. You cannot process it any further. This is the end result. That's what it is. Like all the nociceptive processing, because nociception is processed, and again, I must mark something which I think is important. I do not believe that we can have the experience that we call pain without nociception. I absolutely think, and I'm like 100% sure of it, that we absolutely need nociception to have this experience we call pain.
So the idea that nociception is not needed for pain, you aren't on board with that?
No, and I think it's also resultant from the current definitions of nociception and it's mainly the definition of nociception, which kind of includes tissue damage and or threatened or potentially threatened tissues, and that's because of that. Because if you use, and it also includes, nociception is the processing of a noxious stimuli. Now, once you remove the noxious stimuli, you can understand that nociception can happen without noxious stimuli, and we have a lot of evidence for that. We have evidence from of what is called now neuroimmune crosstalking, like aberrations in the immune system itself can cause the release of chemicals that sensitize nociceptors without actual tissue damage, and that results in like firing of nociceptors, and there is no tissue damage, but we know it can happen. So once you remove the necessity of a noxious stimuli from the definition of nociception, you can move on and realize that nociception is absolutely necessary for pain. But if you use the current definition, then yeah, you can say that a noxious stimuli is neither necessary nor sufficient. Okay, but if you just say, let's remove this, and you can see how nociception is right there in the logical equation that you must have it. Now, a lot of people who love the brain and think the brain is like the cause of pain and stuff like, they don't like it because it threatens their concepts and stuff like that. And again, like, we have a lot of evidence that we can have nociception without noxious stimuli. Like,
I want to pause a bit here because there's a lot of really interesting concepts. So the first one we were talking about is pain reprocessing or pain processing, which basically is kind of straightforward. Like, pain is not a thing. You can't physically take pain and reprocess it. Really, what you're doing with patients is you are helping them to process nociception in a different way.
Well, I would hope so. I don't think so. I if there is one thing that our nociceptive system is, well, my colleagues and I are now, we prefer to call it a nociceptive apparatus. Okay, our nociceptive apparatus is very persistent in doing what it's doing. It's very difficult to interfere in those biological mechanisms that are ongoing in the nociceptive apparatus. And I think like the research pretty much shows it, like most stuff that exists, it's not that good, you know. It's like, that's the reality we live in. Like most of the interventions are like mediocre towards not effective.
Single interventions are pretty poor outcomes, so to speak.
Exactly. So I don't think we really can affect. We can have an effect on the short term, and there are many things that can interfere or benefit patients on the short term, and almost anything can benefit them on the short term. But eventually, most persistent pain states, they persist. Otherwise, they wouldn't be called persistent.
True.
Or chronic.
True. However, there are, and probably you and I both know, even clinicians that have had chronic pain and then have been able to, quote unquote, 100% alleviate their pain. So are you saying that clearly their pain wasn't reprocessed. Are you saying that the nociception wasn't kind of reprocessed, or is it that something that occurred in their life just changed their experience of pain so that it no longer exists?
That's an important point. So nociception is the biological level, and a lot of things can affect the biological level. And we do have good research that points that physical activity is beneficial. Now, of course, I think it's the best thing we have today. It's not optimal, but it's a pretty good, decent intervention to alleviate just a bit chronic pain. And people who have chronic pain and they like you help them alleviate it just a bit, that's significant. Like if they're like constantly on a pain level of 7 and you get them to like 4 or 5, for them that's really significant.
Yeah.
You don't cure them, you don't heal them, but you do help them a bit. So again, it's like we're far away from like healing persistent pain states, but we can help them a bit. And we know that, for example, another thing that is very linked with chronic pain states is a high BMI. So if you get them to lose weight and you get them like, I think there's some evidence for change of diet for fibromyalgia. Again, it's not high quality evidence, but there's some evidence for that it can help them. So when you combine those things together, you get some sort of a small effect. It's not what we would like, but it's the best we have today. So there's a clinical message here, I think, that
Sure.
we can probably like help them improve their quality of life a bit, which for them might be significant.
Yeah, and I've written papers on those topics, especially nutrition, and how, obviously multimodal interventions, specifically nutrition and increasing physical activity, do help people with pain. However, as you and I are talking right now, kind of the zeitgeist, so to speak, is that pain is an output of the brain. Without the brain, you'd have no pain, et cetera, et cetera, et cetera. We're kind of immersed in a very neurocentric, brain-centric world. I mean, I spend most of my time if I go on social, I spend most of my time on Instagram. And there's a couple of people on Instagram, they put things up that says, pain is always about the brain. And then people chime in with, high fives and and I read it and I'm like, this is duality at its best.
It is.
Because you're taking away everything from the neck down, you're taking away, which makes no sense because what happens in your body informs what's happening in your brain. But yet we have clinicians from all walks of life. Most of them are physical therapists and some of them are mental health providers that are really just pointing people just toward cognitive interventions only. Do you see a problem with that?
Yeah, sure. I don't buy that. No,
I don't buy it either.
Now, I
is it a component? Is it a useful component?
No, and I don't buy that, and I don't buy into the brain stuff because it really depends how you look at it, and those people ignore the fact that you can look at it from a totally different now. And I always give this example, like if you look at it evolutionarily, it doesn't make sense, all this brain stuff, because the brain came in a lot later in evolution. Mm-hmm. Okay, we first had a nervous system, and we first had a nociceptive apparatus. It came way before the brain. Okay, so the brain, the way I see it, the brain is kind of superimposed on the nociceptive apparatus. Mm-hmm. And you can also look at it from a totally different way. Like people say, like, oh, the brain is the commander in chief. And I say, no, the brain is a blue collar worker. It's there to help the organism. And it's got so much stuff to do. Like the brain is the organ in the body that does the most. Like it does so many things. It's like overworked, overstressed. It can't be the commander in chief. Like it just can't be. And there's a great paper about it, which I really like. It's called the blue collar brain hypothesis, which looks at it that way. It says, no, the brain is not the commander in chief. It's busy with so many things all the time that, like, it's overworked and overstressed. And again, if you understand that the nociceptive apparatus was there before, like since the beginning of life, there was danger. And the nociceptive apparatus came early in evolution because it needed, like life forms needed an answer to all the threats that were around. And later, like evolution reserved like all those things that ended up to be our brain, because it works, it's good, it's beneficial, but it's not like it's not about the organism. Like it's not that the organism is the brain. The organism was not a brain way before it had a brain.
Right. It's interesting. So yesterday I interviewed a psychiatrist. He wrote a book called The Embodied Mind, and his name is Dr. Verney, and he really is kind of bringing to light like our human experience is an embodied sensory experience, really, and that we, in some ways, we put too much emphasis on the brain. In his book, he has this really great example of an adult, normal guy, married, family, kids, work, no problems, and something happened in his history where he had to have I believe it was a X-ray of his brain, and they found a huge hydrocephalus in his brain, so large that his brain tissue was just a really thin layer. Like you basically couldn't even tell there was a brain there, other than like some brainstem down, kind of near the foramen magnum. The point is that there's so much wisdom in your body that we can access and use. But right now we're in a place where everything is about the brain, neuroscience, the brain in pain. Like it's like we can just sit people down for 2 hours. We can talk to them about pain, which is basically pain neuroscience education. And then things are just going to change dramatically. And the truth is, it doesn't work like that.
No, it doesn't. And again, it's just a philosophical view, like being a brain-centric or a neurocentric. It's just one way of looking at things, and people don't realize it. And there's a tendency to present that view as if it's the only scientific view, the only valid scientific view, and it's not. Like I said here, I presented now a perfectly valid scientific view from an evolutionary perspective that doesn't add up for the brain to be like the commander-in-chief.
Right. The head honcho, the CEO, it controls and rules everything, right? And I'm like, if pain is an experience, that means your whole body is experiencing it, which essentially means potentially every system in your body is experiencing pain in some way, or is reacting to pain in some way.
Yeah, well, the nociceptive apparatus is widespread. It's like it reaches everywhere in our body. So it's not wrong to say that nociception is a whole organism response. Now, there's also a tendency to view nociception as being afferent only, like being only as ascending. But Charles Sherrington, the famous neurologist, he already he was really like, I think he was way ahead of his time. He was amazing. Like he addressed it as an afferent and an efferent response. And for example, all our tendon reflexes are afferent and efferent. Like it's like a reaction and like it's like a closed loop, and also nociception. So all those cognitive aspects are kind of hardwired into that response. It's like that's a good way to look at it. It's like an afferent and an efferent, a hardwired response. And yeah, people like, I think like we're gonna get a lot of backfire for saying a hardwired response, like, oh, it's like going back to the card and stuff like that. But for those opposers, I'm going to say that I'm not talking about a hardwired nervous system. I am talking about a hardwired apparatus, a hardwired nociceptive apparatus. That's not the same as a hardwired nervous system.
Right. And ultimately, if the brain was in charge of all this, I think probably in some way we'd see greater outcomes on things like cognitive behavioral therapy or, all the various
Oh, that is totally my argument all the time. Like I
cognitive
said,
interventions that we have. I mean, there's the argument to say that we just haven't perfected them yet, right?
no, 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 no. That's I don't buy this argument. Like because it's like CBT is being studied now for 2 decades now.
Yeah.
CBT, mindfulness, ACT, all those things are being studied for almost 2 decades. Like there's thousands of studies. We should have been able to see some sort of an effect if it was there, but like the effect is very underwhelming. And that's constantly my argument, that if pain was really like a psychological, pure psychological thing, we should have been able to see some sort of an effect.
Right. It's not a pure psychological thing. And I know this is going to be tricky for me to say. I wonder, I'm a strong proponent of mental health, but I wonder if we frame pain as a psychological problem, so to speak, how that looks to people with pain.
It's horrible.
It's horrible, right?
It's horrible.
Horrible.
It's horrible. Like there's no other word for that. Pain, again, like I said, you cannot have the experience we call pain without activation of the apparatus. Now, like when I say that, a lot of people tell me, hey, yeah, but what about emotional pain? And I'm like, okay, this is where it gets a bit tricky, because we are using the word pain again as a noun, like we're using it as a metaphor for like, my boyfriend really hurt me, like when he, I don't know, when he cheated on me with that girl. It's not, we use the word here in this connotation, like as a metaphor, like that what we experienced is like as bad as tissue damage. Like we want other people to understand that, but it's not really like, it's not equivalent to pain, the experience of like associated with actual or potential tissue damage. It's not that. People use it as a metaphor, and people who keep coming back to a doctor and they complain about pain, it's not a mental issue. No, it's not. It's a biological problem of persistent activation of an evolutionarily reserved apparatus of nociception.
But people see, for example, there's good research that people who are diagnosed with depression, oftentimes their primary complaint is pain, whether it's back pain or neck pain or whatever the pain is. And when people hear that, because it's embedded in the DSM-5, which is what the mental health professionals use, then, well, that person's pain is psychological, so to speak. But I really think if I can read forward a little bit, I think what you're saying is that if someone had something happen in their life that causes them to have a major depressive episode, or they're experiencing grief from the loss of a loved one, so to speak, those are negative emotions. And negative emotions, we know, produce inflammatory chemicals in the body.
Okay, yeah, that's a good point. Now,
which could then excite your nociceptive apparatus and cause pain. So it's not necessarily, it's not purely, because one of the reasons why I enjoy your work is because I personally think that there's a place for working with someone on what I consider their mindset. And there's a lot of different ways to do that. But I think we've gone way too far over to the edge of, we're just going to fix this with education and psychology, so to speak.
Yeah. Now
which is not a pot. Look, I teach courses on psychosocial aspects of pain, but I'm always very clear to say, this is a component. This helps you work with someone in a different way. It helps them understand their experience in a different way. It helps with their motivation, which maybe even be the most important factor, but never that you're just going to use this and this alone, and it's going to alleviate their pain.
Yeah. Now, this is a very important issue that I try to stress a lot. Now, yes, psychological events are capable of initiating activation of the nociceptive apparatus. Yeah, like the HPA axis, for example,
Right.
Yeah, like the
Stress
like stress and emotional stress can
or distress.
activate, or distress can activate the apparatus. Now, what happens is that, yeah, like pure thought initiated the process of nociception, but then again, what happens is that some people have a tendency for those biological mechanisms to fail. And this is an epigenetic genetic tendency.
Mm-hmm.
And that's where persistent pain starts. Now, once the biological cascade got initiated and failed to shut down, the problem is no longer psychological. The problem is biological.
Mm-hmm.
The reaction persists because we know that epigenetic switching can maintain those reactions ongoing. And this is no longer a psychological problem. It's just a bad luck. It's just a tendency, or the circumstances of their life happens to be that something in their switches fail, and this cascade keeps on going. But it's not psychological, it's biological. And for example, a lot of work on fibromyalgia reveals that, yeah, they've got problems in their epigenetic switches, and those reactions keep on going, just self-initiated. It's got nothing to do with the brain. It's just like some sort of a genetic failure to reboot itself. And that's an important aspect that people ignore, or people don't calculate or don't take into consideration.
Right. So to return to somewhat of a resting state, basically, where there's not pain. And I think a lot of the research around transgenerational trauma, which in many ways is just transgenerational stress.
Yeah. And again, what they found is like epigenetic switching failures and stuff like that keeps on going, and so
right.
It's a genetic thing. It's a biological thing. It's not a mental thing. It's like it's not. Those people are not imagining it. It's like people with fibromyalgia. They like live with muscle pain from, like, if you ever had influenza and you had like the widespread muscle pain, they live like that all the time. Like that's what they feel. That's what they experience.
Yeah.
And influenza, by the way, if we're at it, is a very good model for those states, like, because influenza, there is no tissue damage. It's just an inflammatory reaction, like all those neuroimmune molecules are being released, and they just sensitize nociceptors without any tissue damage.
Yeah.
And
I want to make sure
these people just live like that every day. That's horrible. And like dismissed it like as if it's in their head, that's horrible.
I want to make sure we point people to another paper that you wrote. It's called Attitudinal Responses to Current Concepts and Opinions from Pain Neuroscience Education on Social Media. And in there, you really kind of go through a bunch of statements like pain is an output of the brain. Pain is not an accurate indicator of tissue damage. The brain becomes addicted to pain. These are phrases that people use all the time now on social media, but you actually tested these phrases, and many of them were, I guess I would say, not okay with people who are in pain. They don't like the phrases, basically. They find them to be negative.
Yeah, so what we did, distributed this questionnaire on social media. It's the largest study ever made on PNE.
Right.
It's 1,315 respondents, and we also designed it like an experiment. What do I mean? Like an experiment? Like we directed people into 4 different groups. Like we asked them, "Are you a practitioner?" Yes. "Are you a practitioner experiencing pain?" They were directed to practitioners plus chronic pain group, and we had like healthy controls. We had people with chronic pain, and we had practitioners, health practitioners without pain. And we wanted to see, like, we needed those groups to show the differences, like for comparison, like, because if you only give it to people with pain, you can you're not going to know how different they are compared to other people. And we gave them a list of 10 statements. Now we worked a lot in like we made an expert committee, and we went through a lot of statements. Like every expert brought in his statements, and we went through we funneled many statements until we came up with those 10 statements, and we just like asked them like, what do you think about it? And we gave them we gave them words to choose from, like words that it's I don't remember, what was it, condescending, helpful, useless. And what we did, we gave valence to those statements. Like, for example, useless is like negative, right? It's like, oh, what can I do? It's useless. It's like negative. Helpful gets a plus. And then we just like dichotomized it like binary, like good reactions versus bad reactions. And we looked at the proportion, like the percentages of differences between them. It's quite straightforward. It's not really that complicated. And yeah, like most of the stuff that came from P&E, people with chronic pain didn't like it. Now, what was very evident was that the practitioners without any chronic pain, they loved it. Whereas the healthy controls were kind of like neutral. Like there was also like we did something in the statistics that if they gave one answer positive and one answer negative, then they get a neutral, like a 0. And they were quite neutral about it. They were like, okay. And we found out that healthcare practitioners with chronic pain tended to be like the controls. They tended to not really like the statements that much and not really hate them that much. They were ambiguous about them, ambivalent. Like, if you maybe ambivalent is a better way. They were unsure. And so like it's pretty clear that you've got those healthcare practitioners who never experienced persistent pain in their life. When you put them head to head, like it's like the exact opposite from those people with persistent pain. Like they loved it, and those with persistent pain hated most of the statements. It was quite clear. Now, of course, there were people within the persistent pain group that liked some of the statements and they were good about it. Of course, and that's what you expect. You expect a normal kind of like a distribution, so not a normal distribution, but you accept when you give multiple choice, you expect to see some distribution between the choices. And it was there, like, yeah, some people were like, yeah, I like it, I find it helpful and stuff like that. And again, it's really it was really interesting because you can see head to head that like you've got those two groups that are totally the opposite, and then you've got like those healthcare practitioners that what we think is that their experience of persistent pain moderated their enthusiasm from those P&E statements. They were like, I guess I'm not buying it because like it doesn't match up with what I'm experiencing.
Right.
So and a lot of the criticism that we got like from people on social media was like, oh, this study is not clinical. It's like those sentences and phrases, they need to be used in the clinic in the right context. And I don't buy that argument. I don't buy that because most of the like a lot of the developers of P&E programs, that's what they do. Like they take them on social media and apps for your mobile, and they just show you like those memes like oh, pain is an output of the brain, and that's what they do. So I'm like, and that's why we did like this study, and we said it was valid to do it on social media because all those P&E stuff became very abundant on social media, and people like are getting exposed to it. So it's a valid setting to check it.
I after reading a lot of this research, and I really think a lot of this comes down to the individual's expectation. So if you're someone who has had chronic pain, you've been to all the doctors, you have all the x-rays and all the MRIs, and you've arrived to the place where you've said, this is definitely not about my knee. And someone says to you, hey, pain is about the brain. Then that meets your expectation. That makes sense. But if there are other people that are like, well, okay, so let's say pain is controlled by the brain. All right, maybe I'll buy that. But how does that really help me? How is it helping me right here and now? And for those people, they're like, it's not a solution for my pain, so to speak. So it's
Yeah,
interesting to think about what people's expectations are when they come into different types of cognitive interventions. And I think the CBT and the ACT world show that too, like the idea of being able to change someone's thoughts versus the idea of just kind of allowing thoughts to be, or two different types of thinkers almost on some level.
yeah, and you know what? Here again, I say that there's a third way. There's a third way, and I stopped pretending that I can change the way people think. I stopped pretending that I can reframe
Right.
their thoughts or stuff like that. I don't do that anymore. Like what I do now is I call negotiation. I negotiate the meaning with the patient. Like you said, like the doctor told me I've got a bad disc, like a herniated disc, and it's not going to heal. And I instead of like reframing it, like saying, oh, discs heal and stuff like that, I just ask them, have you considered that maybe what he says is not an absolute truth, and there are other opinions, and like we know some other stuff today. So have you considered that you might like, are you going to be open to listen to new information? And that's negotiation. It's not, I'm not like, oh, I'm going to reframe this guy, like to reframe his thought. I'm offering, I'm like, you come to me and I'm going to offer you like a new insight, a way to look at things different. Would you like to hear about it? And I find it a lot more grounded to patient relations and human relations and stuff like that. Like I don't know, like we see it in our everyday interaction with people. Like, some people like have a preset like mind, they've made up their mind about a certain topic, and there's no point in trying to change their mind or reframe it. And you're like, would you like to listen to me, or just, I don't know, I can offer you my insight if you're willing to listen. And that's always, I find it a lot better. I don't try to do an ACT or a CBT or anything. I just like, hey, I don't know, we can try to maybe try to discuss it in a different way.
Yeah,
So
using your human skills a little more organically, so to speak.
Yeah, I don't know, like I find it a lot better. It's like it causes a lot less tension. Yeah, I find, like when I started, like when I did the first P&E course, like almost a decade ago, and I came out and I started using it, and I found that people were very, very resistant to it. Now, another reason that we did that study is because I saw many patients that started coming to me from colleagues. In the beginning, some of my patients didn't like what I said to them, like that was like kind of P&E stuff like that. They didn't like it, and I was like, I had to rethink stuff. And then I started seeing those people that come from my colleagues and tell me, oh, this guy told me this and that, and like that it's in my head. And I never saw any mentioning of that in the literature. Like it's like the literature presents P&E as like a benign intervention, and I'm like, come on, like I was like I saw many people like who didn't like it, like who were like appalled by that, and that's why I designed that study to try and show that, like, of course, the way we designed the study is to be able to falsify also what I thought. Like, I had to design it in a way that will not affirm my suspicions, and that's why we did like grouping, and we did like we did a lot of statistics that, like we did the statistics that cancel each other, like to give them a neutral, so it won't like end up like the way I framed. And also we didn't like we alternated like the words, like it was positive, negative, positive, negative, positive, negative. So like we want to have a certain order that can influence the way that like all those are negatives and all those are positive. We like kind of like mix them together. We did a lot of debiasing for the study, so like that it won't show up what I think. And
right, it doesn't shape someone's opinion as they're reading the questions, basically.
Exactly. And we just like asked them, what do you think about this sentence?
Yeah.
And then like we gave them words, and we also gave them free text. Now we are working on the second part of that study. I hope we'll be able to publish it. One of my co-authors is the guy who did the artificial intelligence part. We took all those free text responses, like 13,000 free text responses, and we put them in an artificial intelligence program, and that program synthesized synthetic narratives.
Mm-hmm.
And so for each statement, we now have like a synthetic narrative. Like the computer program takes all the words that all the people that with a negative attitude towards that statement had, and it compiles a narrative. And it's quite amazing. Like the narratives are like really readable. It's like a person says that to you. It's quite amazing. I'm really looking forward to publish that. But again, the guy who does that, he's got a lot on his mind, so we're like halting it. But I already put some stuff on Twitter, like a synthetic narrative that people like were like say, like the people who didn't like the pain is in the brain, or pain is an output of the brain. Mm-hmm. All the people who didn't like this statement, the synthetic narrative, if I remember, it goes like, I don't understand why you're saying that. Pain is obviously not in my brain. Uh-huh. It's a sensation in my body. It's like, right. It's quite amazing. Like when you read the statement and you read the generated narrative, it really reads like a person in front of you. And we've got like neutral narratives, and we've got the positive narratives, and you can compare them. You can read them. Like it's a really wow. It was really exciting. Like because analyzing 13,000 text responses, that's crazy. Like but we already did a study, like it was published last year, and it's unfortunate that it wasn't noticed, because it's practically the largest qualitative study ever about people of people with back and neck pain.
Yeah, that's the one. It's called Individuals with Back and Neck Pain on Medical Forums. What do they mention? What do they fear? And I appreciate it, because as you mentioned, it's a large kind of qualitative study, and you get really good input based on what the person actually thinks and really in some way values. They're not valuing that pain is in their brain. There's no value to that, really.
Really, there isn't. And it's a huge study. Like we took 13,000.
I should say there's limited value to that, depending on who you're working with.
I agree. Yeah. Now, but I think we were able to synthesize many useful narratives over there. Like you see, like the number one thing they fear of is like surgery procedures. Yeah,
I heard that too. So everyone's focusing on like fear of movement, and I'm like, you probably, based on this study, you probably should sit down and talk to your patient about surgery the first couple of visits, not fear of movement, because that's not the fear that they're concerned about. If you can calm that fear and let them know that most people do really well with physical therapy and they don't have to have back surgery, then that's better than fear of movement, or it's better than, hey, pain is in your brain. Let me show you how,
and people come with back and neck
how we can reprocess the pain, basically.
And if you read our study, you can get real good clinical insights. Now, this study was, again, we utilized computer algorithms to analyze all those narratives from people's questions in medical forums online, and it's got huge amount of clinical insights that people can gain. And again, like you said, like surgery is the stuff that they're most afraid of, or even injections and medications, they're afraid to take them. And it has gone completely unnoticed. I think it's already 2 years now. It hasn't been cited even once. And again, it's the largest study ever. It's like I haven't seen any qualitative study with 13,000 narratives that were analyzed.
Yeah, it's huge. It's a huge study.
Yeah.
I have to say, just we've talked about a lot here today, and I want to make sure you mention where people can find you and follow your work before we finish up here. But I think the most important thing that you've said, or the thing that's most impactful to me, is when we look at all the cognitive interventions. So, these are all your pain education approaches, your mindfulness, your ACT, your CBT, and this has been studied now for decades, with a lot of money and a lot of quote unquote brain power going into it, right? Or body power, shall we say. None of those studies talk about adverse outcomes, or very, 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 very few talk about adverse outcomes, and very few have a qualitative component where they ask someone's perceptions and look at, did they perceive this to be helpful and useful or not?
Or not, yeah. The or not is never asked, is hardly
Correct.
ever asked. And that's what we wrote in our paper about P&E, is that like there's a certain, it's called framing bias.
Mm-hmm.
Like the way you frame your study, it's like whether you allow people to express negativity or not. And now, if you're only allow them to express positivity, then it's going to show that it's a positive study, and that's like highly biased. And that's why we wrote that in the context of the current existing literature about P&E, our study is unique because we're the only ones who actually ask them whether they don't like it.
But it's fascinating because I had a psychologist on years ago, and she actually asked me during the episode, she said, do you know what the mean number of visits are for someone when they come in for pain psychology, in essence? And the answer was 1. That most people come in, when they see a psychologist for pain, they're coming in for maybe 1 or 2 visits. Now, there's a whole lot that has to be unpacked with that one statement, because there's social structure built around psychology. There's bias, there's stigma. I don't want to overlook that, but in one sense, you're saying we can cure pain with just working on cognitions. Then you're saying, well, here are the studies there of minimal quality and minimal outcomes. And just so you know, most people come in for 1 or 2 visits and then they don't come back, basically. So it tells me that there's something that needs to be improved there, right? Or there's something that just doesn't work.
It doesn't work because, again, I tend to think that most people don't buy that. And for a good reason, because like someone with fibromyalgia who is living like with influenza-like type of pain all their life, and this guy comes to him and says, oh, you got to work on on your positivity and stuff. It doesn't make any sense. Now, look, I have chronic pain. Like I live with headaches since I'm 13 years old. I have really bad chronic headaches and also irritable bowel syndrome, which goes with a lot of fatigue and stuff like that. And like, I know what it is. It's like someone told me that, like, which is strange. Like, I don't know, like I told you, like at first I tried to play around with P&E, and when I started seeing a bit of reactions, that's like I immediately caught myself and like thought like, wait a minute, why do they react like, wait, what have I done wrong? And then I started thinking about myself, and like again, I stopped buying that. Like, and it didn't take me that long, but people with chronic pain, like they know what they're experiencing. They know better than you.
The one theory that I've seen that I think holds some good weight, I think, is the theory of embodied cognition. I don't know if you're familiar with it, but it really, it kind of gives equal weight to the idea that you have a brain and a body, and all of that is embedded in a social context, instead of, well, you have these thoughts and emotions, and if we help you kind of change those thoughts and emotions, then everything's just going to be hunky-dory.
Yeah, I don't know. Again, like when I sit alone at home with my headache, I'm not social. Like
Right.
it's me and my headache. It's just basically it's just me. Again, like pain is not a separate entity from me. Okay,
Mm-hmm.
which is also another like it's called a reification, like reifying pain, like turning it into a concrete thing which is outside of you. No, pain is a part of you. Like it's like it's not something that causes you to do stuff. Like pain cannot cause me to do anything. Pain doesn't move me around. Like it's a part of me. Okay, it's an essential part of me. I can't dismiss it. It's me, and that's why when I'm alone and I'm not around social people, like it doesn't matter. Like that's why I think we like a lot of stuff that like we learned to say in the last 2 decades, like pain is biopsychosocial, all those things, like all those mantras, we have to rethink them because like pain eventually is a biological reality for all the people that experience pain. It's a biological reality. It's not a psychological thing. It's not a social thing.
Right.
That's what I tend to think. Yeah, of course. Yeah, like you're a human, like embedded in his environment, and yeah, you live with people, and yeah, this is also kind of biological anyway. It all goes back to biology.
But everything is affecting a biological process in your body.
Exactly. So eventually everything is biological, even psychological is biological.
Correct. Yeah. Asaf, it's been great chatting. This is probably the longest podcast I've ever recorded. I appreciate your
Okay.
research. I appreciate your time and your effort, and yeah, the talk, and just helping all of us think differently, because ultimately that's what research should do, right? Help us think differently. And then with that, hopefully there's progress. Can you let everyone know how they can follow you and learn more about you?
You can find me on Facebook. Just write Asaf Klaf, Klaf, or you can find me on Twitter, Asaf Weisman or Asaf Klaf Weisman. I have a blog. It's called Painlosophy. It's on WordPress. So yeah, painlosophy.wordpress.com, I think. Yeah. I'm kind of active lately on Twitter. Yeah, you can find me there. On Instagram, I'm not that active, but I have a ResearchGate profile. You can find me there. Asaf Weisman. You can follow my publications when I release new papers.
Great. We'll, of course, link to all that in the show notes. You can find that at the IntegrativPainScienceInstitute.com. Please make sure to share this episode with your friends and colleagues who are interested in pain science and nociception. And tag us. Tag Asaf and tag me, and let us know what you think of this episode, and if it helped you understand pain on a deeper level, and maybe gave you some insight as to how you can treat and potentially alleviate your pain or your patient's pain. I'm Dr. Joe Tatta. It's been a pleasure, and we'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit IntegrativePainScienceInstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.